But I would like to introduce to you all Dr. Alice Swenson. We're really happy to have you here today. Dr. Swenson is a pediatrician who specializes in child abuse, and she's a staff physician at the Midwest Children's Resource Center, which many of you know, and I think she'll introduce and maybe talk a little bit about it, but it is kind of the place where some of the more serious child abuse cases go. And she's going to be focusing on how to identify injuries that occur during maltreatment. And I also want to acknowledge Dr. who helped us in our current report that we are working on child fatalities in Minnesota. I've mentioned this several times, but this is a report that covers everything, the governor's task force in 2015 up to mid-2022 this year. And so
I'm watching a webinar.
And we have a number of case studies, and we had some subject matter experts case studies and give feedback, and Dr. Swenson was a key person and helped us with that as well. So I'm going to let you, Dr. Swenson, introduce yourself further. I only just want to say to people that we will have time for Q&A at the end, and we'll take it from there. So please go ahead, Dr. Swenson.
No. Thank you. And if I could remind everyone to mute their microphones if they're not actually me. So, because I can hear a lot of talk and it's just going to distract me. So I'm Alice Swenson. I'm a pediatrician at Midwest Children's Resource Center, as was mentioned. I'm actually a child abuse pediatrician. So child abuse pediatrics is a board certified subspecialty as of 2009. I was board certified that year. And I work with Dr. Mark Hudson here at Midwest Children's Resource Center. I've been here for 8 years. Prior to that, I was at the Children's Hospital of Wisconsin in Milwaukee. And prior to that, I did my fellowship here at Children's Hospital at MCRC in child abuse pediatrics. And so what child abuse pediatricians do is we're trained in the evaluation of in part of physical injuries that occur during child abuse. We also do evaluation of sexual abuse, but today I'm going to be focusing on the injuries that occur during physical abuse. So I'm going to share my screen now. Let's see if I can make this work. Share. And can you see the slideshow now?
Yes.
Okay, great. So let's go ahead and get started. And I will warn that this presentation does contain disturbing images. So everyone should be prepared. These are images of children who have been abused. So they are upsetting to some people. So just be aware of that. So MCRC is a child abuse pediatrics clinic of Children's Hospitals and Clinics of Minnesota. It's a child advocacy center. So if you're familiar with child advocacy centers, they are set up in order to centralize the care that children receive when there's suspicion of child abuse. We provide consultations and case reviews. We have a 24-hour phone triage and advice line. That's our telephone number. We can also be reached through physician access, and that's their telephone number. And then I'm going to just jump right into physical abuse cases. So I have way more slides than I can possibly get through. So I'm going to talk a little fast, but hopefully you'll be able to keep up and let me know if you need me to slow down or if you have any questions. So identifying physical abuse. Let me take that out there. Okay. The most important elements in identifying physical abuse are history, and then the physical exam, and then lab and radiology. So when we take the history, it's really important to remember that medical providers are not investigators. It's really incumbent on us to talk a little and listen a lot. I think if you watch me take a history, you'll hear me say, and then what happened a lot. It's important to document the description of the injury, and that includes photographs, as you'll see, to identify the caretakers and adults present at the time of injury, to use quotes when possible, and really provide just a wealth of documentation to make sure that you're documenting everything that's said. So ask for details, what happened next. Make sure that you control information exchange. So if you provide information like offering possible explanations for the injury, that's going to be woven into the history. So just don't provide possible explanations, just ask questions. Did the child fall? Did they drop? Have there been any injury events? But don't provide possible explanations like, did you squeeze the child? Did you shake the child? And obviously we don't do things like accuse a parent of hurting their child. So history red flags, the most important things that, we're pediatricians, so it's important for us to be aware of things like developmentally inappropriate histories. Things like, I put the 2-week-old on the middle of the bed and they rolled off the bed and fell on the floor. Well, that doesn't make sense because a 2-week-old can't roll yet. So that's why we're pediatricians, so we know things like a 2-week-old isn't able to roll yet. No history in a very young infant, for example. So recently I saw a 2-month-old with a clavicle fracture. Well, clavicle fractures are common accidental injuries, but there was no history of trauma. So this is a very young infant with a clavicle fracture and no history of trauma. That's concerning for inflicted injury. Delay in seeking medical care, that can be concerning for inflicted injury and child physical abuse. A changing history. So if a parent knows what happened, the history shouldn't change. There should be a straightforward history. And then a history that's inconsistent with the injury. So there have actually been a number of studies about short falls in children. So falls off of couches, falls off of beds, falls out of cribs. And those are considered short falls, and those generally result in no injury at all, or occasionally like a single bruise or a minor injury, not major injury. So a history of a short fall should not result in a severe injury, or an injury inflicted by a small child. Generally, small children do not inflict major injuries on other children. So let's jump right into bruises, because that's what our most common complaints that we see children for when there's concern of possible physical abuse. So this is a case report of a 4-month-old female. She was brought in by her mother with concerns of easy bruising. It first started at about 1.5 months of age. She had bruises around her mouth, reportedly from her pacifier. A couple of weeks ago, she had bruises on her arms, legs, and trunk about an hour after her dad was kissing her and making her giggle. She also has some scabs and peeling behind each ear. She seems happy. She's constipated, but that's improving. On exam, she has bruises on her cheeks in the area around her mouth, the perioral area. She has no other bruising or petechiae, or those are little dots of bruises noted. Everything else about her skin is generally pretty normal. She has some dry, flaking skin on her ears. And then the diagnoses and associated orders for this visit, the description that the doctor gives is easy bruising. The differential includes platelet dysfunction. So those are the cells that are involved in bruising. Clotting disorder, hemophilia, von Willebrand's disease, which is a type of bleeding disorder, leukemia, physiologic bruising, which is actually not a real thing, and child abuse, which for some reason this doctor is not suspicious for, likely because it's an intact family, which is one of the things that makes doctors not suspicious of abuse. They aren't able to get all the labs that they want, and they say that they're just going to follow up with the family and make a further plan. 5 days later, this child comes in with bruising on the ear, both ears, bruising on the chin, bruising on the arm, which looks like a bite bruise, bruising on the buttock, a femur fracture. And so this is multiple injuries now in this child. and could have been avoided if this doctor had said, well, this is a baby with bruising. And this is what's called a sentinel injury. So there was a study done out of Milwaukee while I was there, where they looked at, and I'm going to focus on the this group here, 200 children with definite abuse, 100 of them with abusive head trauma, and 100 with non-abusive head trauma. But 27.5% of these children had what's called a sentinel injury, or a bruise, or some kind of injury where 80% were bruises, and 42% had a medical provider aware and went on to be injured further, 100 of them with abusive head trauma. So what this study basically is telling us is that these are, when an infant is injured and sometimes severely injured, oftentimes there's an opportunity to prevent the injury. If a doctor had said this infant has a bruise, they shouldn't have a bruise, I should be aware and call child protection before they get injured further. So what is a concerning bruise? Well, a concerning bruise is a bruise based on that's concerning because of the child's development, the location of the bruise, and the pattern of the bruise. So you've heard me talk now about bruises in babies. So this was a study done in 1999. They looked at 973 kids less than 36 months old. 20.9% of them had bruises. So this is 3 years old and under. 51.9% of walkers had bruises. 17.8% of cruisers, so those are the ones who can pull themselves to stand and cruise along the furniture. 2.2% of pre-cruisers, so that's any kids who couldn't pull themselves to stand and pull themselves along furniture. Only two children had any bruises at all, and only one child less than 6 months old had a bruise at all. And their conclusion was that those who don't cruise rarely bruise. So that's one of our mottos in child abuse pediatrics. So babies, infants should not have bruises if they're not yet ambulatory, if they're not yet moving on their own. They also noted that bruises on the face and trunk were rare, and no bruises on the hands or buttocks were observed in these children. So bruises that are accidental are often in expected places. Anyone here who has kids of their own knows that they often get bruises in places like their shins, their forehead, over bony prominences, basically, because that's where the tissue gets squished between the bone and whatever is hitting the outside of the skin. Whereas there are places that are unusual to get bruises, like, for example, the butt, which is big and squishy and doesn't have bone right underneath it. I mean, there is bone in the buttocks, but it's way down there underneath the big squishy buttock. Genitalia is a very uncommon place for kids to get accidental bruises. The squishy part of the cheeks, the ears, the neck, these are all uncommon places for accidental bruises. And so this is just another schematic for you to help picture the blackened areas are areas where children shouldn't be getting bruises, and the white areas are places where kids do get bruises more commonly. So then there's bruises that are patterned. When a child is struck by an object, a shape or pattern is left on the skin. Examples, most common thing that we see these days are phone charger cables, but hands, belts, shoes, brush, cords, those are things that we see as well. Not really something that you confuse with a disease condition. So it's not like you would see a child with a looped cord injury and say, well, that looks like they have leukemia. What happens is that the impact outlines the object, whereas the squeeze, if you have like a low velocity bruise, like a squeeze bruise, then you see the bruise under the object. And I'll show you what I mean. So in these bruises, you can see that the bruising is actually outlining the object that hits the skin, which here is a belt buckle. And then here would be like a looped cord or a looped belt bruise. It's outlining the object that hit the skin. Here again, you can see that the bruising is outlining the object that hits the skin. You can see there's paler areas where the object actually hit the skin, and then the darker areas are surrounding the area that where the object hit. This is a really good example right here. Can you see my mouse? You can see that there's an outline of the cord that hit the skin. Just another example of a patterned injury that is clearly an object hitting the skin. This is bruising of the chest. It's kind of hard to see, but you can see there's bruising on the chest there. This is an example of an area that children typically do not get bruises accidentally because it's a protected area. They typically don't get bruises there. And then these are going to be some examples of slap bruises. What you see is that the fingers are outlined on the face. So you can see that the fingers push the blood out of the way, and you can see outlines of the fingers here as well. This is a really good example. So here is a finger, here is a finger, here is a finger, and then the bruising is in between the fingers. This is another example of being hit with fingers here on the butt. And you can see that there's bruising in between the fingers right there. This is the bruising right here. Now, this is a classic example of what butt bruising looks like. And what you'll notice is that there's sparing of the gluteal cleft because the butt is in anatomic position when it's spanked. And so what happens is you get sparing of the area between the two buttocks and a sort of a linear almost appearance to the area on either side of the gluteal cleft. So it's a very classic appearance of a butt spanking. And so that's what the butt looked like when it was spanked, it looked like it was in anatomic position. And you can see these linear bruises that occur from shearing of the blood vessels on either side of the gluteal cleft when the butt is spanked. It's a very classic appearance for a butt spanking. And these are them, as it fades away, you can still see the linear bruising. And then ear bruising is another uncommon place for kids to get accidental injuries, especially this very confluent bruising of the pinna of the ear, or the cartilaginous area of the ear. So what about telling how old a bruise is? Well, bruises do go through a pretty characteristic color change as they heal. They start out deep purple or red and then become green, yellow, and brown. But they did look at 50 kids who went to the emergency room with bruises of a known age. And they asked physicians to tell how old they were within 24 hours. And ED doctors got about 50% right. And trainees got about a little under 40% right. And other physicians got about 29% right or 30% right. And there was poor inter-rater reliability, which meant that they couldn't repeat the experiment and get the same results. So what they basically concluded is that you can't look at a bruise and tell how old it is based on how it looks. So what we do when we see a bruise is we don't say old and new bruises, and because what we've realized is that you can hit a child and then hit them again, and the two bruises can go through different phases of healing at different rates, depending on how hard the hits were, for example, and where on the body they were. So we would never say old and new bruises when we're talking about bruising, and when we're talking about trying to age bruises. We just don't do it. There's no science to back it up. So then when we do see children who have bruises, we do sometimes do a workup for bleeding disorders. So we get a bleeding history, for example, from the parents. We'll say, does this child bruise easily? We look at the physical exam. So, for example, if it's a toddler, we would look at their shins and see if they have excessive bruising on their shins. And if they do, then be concerned about a possible bleeding disorder. We may do coagulation studies based on if they do, like, for example, have excessive bruises on places where they would expect to have bruises. We would do a skeletal survey, which we'll talk about more when we talk about fractures, but that's x-rays of all the bones in children who are 2 years old and younger. And then we would consider a head CT, especially in children who are 6 months old and younger. We would consider doing abdominal imaging and tests of the liver function to make sure that there's no occult abdominal trauma. And then also keep in mind that kids can have a bleeding disorder and be abused. So just because they have a bleeding disorder doesn't mean that they weren't abused as well. So this is just an example of the workup that we do for bleeding if we are concerned about a bleeding disorder. These are the ones in red are the studies that we do pretty routinely if we are concerned about a bleeding disorder. The skeletal survey must comply with the standards developed by the American Academy of Radiology, which means that we have to do about 19 to 25 x-rays of all the bones, and then we repeat it in 2 weeks. And then ideally we have a pediatric radiologist read the skeletal survey. So the reason we repeat it in 2 weeks is here's an initial skeletal survey of a baby where there was concern for abuse based on bruising. And you can't see anything on this x-ray. I'm pointing to nothing right there. But on the follow-up, you can see that there's multiple rib fractures. And this child was placed in foster care. So those rib fractures were actually present on the initial skeletal survey. They just weren't visualized because there wasn't any healing yet. Those are rib fractures. And then someone did a study looking at whether siblings and contacts of children who are physically abused should be evaluated. And they found that there was actually some good data to show that we should be evaluating siblings and contacts of children who are physically abused, at least by doing a physical exam and a skeletal survey if they're under 2 years old. Probably not a head CT. Those didn't have much outcome, but definitely a physical exam and a skeletal survey if they're under 2, a physical exam if they're under 5. Okay, so pausing to take a break. Does anyone have any questions at this point? Okay, we'll move on to burns. So burns are classified by their depth and extent of the body surface. Superficial, formerly known as first-degree burns. Then there's partial thickness, formerly known as second-degree burns, and then full thickness, which are formerly known as third-degree burns. The extent and configuration, yes? Sorry. The extent and configuration of the burn are influenced by the agent causing the burn, the temperature of the agent, the length of time applied to the skin, the depth of the skin at the site, and the presence of clothing or diaper. So differentiating, these can be really complicated, but pattern, symmetry, configuration, depth of the burn. So uniform depth, for example, can indicate that it's an inflicted burn rather than an accidental burn. It's important to know the developmental capabilities of the child again. Time interval for seeking medical care, though, keeping in mind that a lot of people have folk remedies that they use for burns, like putting butter. I had one person who said that they put toothpaste on a burn. So I'm not always that reliant on delay in seeking care for burns as indicating abuse. But I will say that history and scene investigation are extremely important in evaluating whether burns are inflicted or accidental. Pediatric burns, basically this is a very busy slide that's telling you that burns that are abusive have a much higher mortality rate, and that that's basically what the most important lesson to take from this slide. Inflicted burns, generally, again, on the we're seeing a little bit of a pattern here that buttocks and parent genital area burns are much more commonly abusive. Palms and soles burns are much more commonly abusive. And then the pattern is a sharply demarcated stocking glove type of burn, full thickness, symmetrical. And then whereas accidental burns tend to be more random on the front of the body with splash marks, partial thickness, asymmetrical, smaller, non-uniform contact burn type of burns. So obviously we can't take people into labs and burn them. So we have sort of limited data on what we know about water temperatures. But what we do know is that these are sort of the temperatures where we know that burns start to occur. So 127 degrees. Does anyone know what temperature your water heater is supposed to be set at in your house? You can just pipe up if you know. Well, it's supposed to be set at 120. So you shouldn't be able to get to this 127 degree full thickness burn in even a minute. So whereas 150 degrees, you should be able to get a full thickness burn in 2 seconds. So hopefully nobody in this call can get to 150 degrees in the water in their house because their water heater should be set to 120 degrees. This is a little chart, just basically charting what I told you. And this is a burn scene investigation chart. We give these to our investigators so that they can go through all the information, like what the water heater is set at, how long it takes to get to certain temperatures. Things like if you flush the toilet, does the water get super hot? How long it takes to get standing water? Does the water pool in the sink or bathtub where the burn allegedly happened? So it's really important to have cooperation with investigators on our burn scene investigations. So immersion burns are the most common inflicted burns. They tend to have uniform depth with a distinct wound border, circumferential stocking glove or donut shaped distribution, which I'll show you, and an absence of splash marks. So this is just a schematic of what they look like, and you'll see that there might be sparing of the buttocks and of the heels because of the way the child is sitting when they're immersed. And that's just another schematic of what it might look like. And this is what it actually looks like in real life. And then whereas scald burns from a child, I will tell you that emergency room doctors will say that they hate cup of noodles because kids pull them down onto themselves all the time and get cup of noodle burns. This is a classic cup of noodle burn. Child pulls down a hot cup of water onto their chest, and you can see how it runs down the chest. This is a classic accidental burn. There's a flow burn. It's a spill. It looks like an arrow pointing downward, and the deepest burn is at the point of contact. This is an example of an inflicted burn. You can see this very sharp line of demarcation. This is an immersion burn of a baby's hand.
Oh my God.
Okay, you are unmuted, whoever is upset by the burns. I'm sorry about that. But, so these are, again, scald burns. You can see how they run down the chest, and these are accidental burns. There are conditions that mimic inflicted burns. Interestingly, if children take laxatives, they can get burns in their diaper areas that, well, they look like burns. They're laxative burns. Carpet cleaners, oven cleaners, they can actually get burns from their own poop. And so this is what it looks like when a child sits in their own diarrhea for like a period of time. It actually, because the transit time of the stool is faster, they can get bile in their poop, and it tends to cause basically what looks like a burn. The way you differentiate it from a burn is that it actually affects the perianal area, rather than a burn from, as we saw before, from being immersed doesn't tend to affect the perianal area. This is phytophotodermatitis, which is when somebody touches like a lime or a lemon or parsley or mango, and then touches the skin, and then the skin gets exposed to sunlight. So it's not a burn. This is an inflicted cigarette burn. Very classic ulcerated surrounding tissue, and then this deep cratered lesion. Cigarette burns are 5 to 10 millimeters in diameter, and they tend to be they tend to look specifically like that. Whereas we get a lot of calls with people who are concerned about possible cigarette burns, and there are accidental cigarette burns, but primarily what we see is impetigo masquerading as a cigarette burn, because impetigo can be a circular lesion. So this is an example of impetigo that looks like cigarette burns. It doesn't have that classic central crater. It just has like a uniform appearing circular lesion. So this is a case example of a 2-year-old with genital burns. The parents told the grandmother that the child had, quote, zipped his junk into his pants, and that caused the injuries. And this is the injuries that he had. Then this is an example of a changing history. So the mom's boyfriend later says that he filled a hot water bottle with the hottest water from the tap and put it on the child's genital area, and it exploded. And then when confronted by police, the boyfriend changes his story and says that he filled a sock with raw rice, microwaved it, and put it on the child's genitals. And he says that the child did not complain of pain when it was put on, and sat there with a sock on his genitals for several minutes. The police did a really good scene investigation, and they found this in the garbage out back behind the house. So this is burnt, is how hot this sock full of rice was. And this is a case we had at MCRC many years ago. Does anyone, people don't seem to want to unmute their mic, so I'll just go through and show you what the lesions looked like. And this is a mother who was heating up her silverware on the stove and then putting it onto the skin. Contact burns that are inflicted tend to be deeper and on multiple planes, and there tends to be a delay in seeking care in general. Cigarette lighters, I don't think they have the car cigarette lighters anymore, but these are classic types of inflicted burns. The big lighter has it looks like a kind of a smiley face when they're inflicted. So those are a classic inflicted burn that we do see still. So now turning more towards the internal exams, fractures. This is a 58-day-old with chief complaint of left leg pain and fussiness. Dad reports that he was changing the diaper and he heard a pop. And it's important to have a high index of suspicion when you're making a diagnosis. So this is the fracture in this child. This child also had what's called a bucket handle fracture, which is right here. So the incidence of abusive fractures varies from 11 to 55%, so up to 55% of fractures associated with abuse. The most important risk factor is age. So most abusive fractures occur in children under 1 year of age. 80% of all abusive fractures, but only 2% of non-abusive fractures occur in children under 18 months of age. So basically what this is telling you is that children under 18 months of age don't tend to get fractures in general, unless they're abusive. They don't tend to get accidental fractures. So generally, fractures present in with swelling, pain, decreased movement, but there are certain types of fractures that can present with no symptoms or just general fussiness. So those, for example, are rib fractures and that bucket handle fracture that I just showed you. Those tend to present with very mild symptoms or no clear symptoms that you could identify, like these types of fractures would present with. These huge femur fractures or big, large fractures like these, you would tend to expect the child to present with very obvious symptoms, but there are other types of fractures that would tend to present with sort of more fussiness and irritability rather than a clear swelling of the extremity, for example. So types of fractures, there is transverse, there's oblique, there's spiral, and there's comminuted. There's also buccal, which is like when just one side of the bone sort of cracks open a little bit or cracks into the side and then doesn't go all the way through. I'm not showing that because that's a more accidental fracture. So the biomechanics of transverse fractures, which is this type of fracture, is basically like if you took a pencil in your hand and just snapped it in half. The fracture line is perpendicular to the long axis. It's a tensile or bending load, or it could be a direct blow, for example. Whereas your spiral or oblique fractures tend to be more of a twisting kind of motion. So twisting around the longitudinal axis of the bone. So we tend to see these fractures in when they're abusive in, say, a baby where the diaper is being changed and the leg is sort of torqued out of the way, really in a really frustrated fashion. Whereas the buccal fracture, remember I told you it was kind of like a little portion of the bone buckled in on the side. These tend to be a fall on an outstretched extremity. So landing and with the pressure sort of transmitted through the bone. These are fall on outstretched hand, much more commonly accidental fractures in older children. So 2-month-old with a femur fracture. So the femur is the biggest, hardest bone in your body. It's your upper leg. Healthy infant, appeared well when put to bed. Woke up at 6 a.m., fed well, brought into bed with parents. Woke up at 10 a.m. crying and inconsolable. And this is the fracture. So far the explanation is no explanation, which is very concerning because you have a very young infant with a very large fracture and no history of trauma. So the next explanation is the mother woke up to find that father had rolled over onto the child. Mother rolled the father off the child, and the father and the infant both remained asleep, and mother didn't tell because she was afraid someone would accuse them of hurting the infant. Well, the problem with this story is sort of multifaceted. First of all, you have the idea that the father could have caused this fracture by rolling onto the infant. It doesn't really make sense from a biomechanical standpoint. The second problem is that the idea that the child would have remained asleep when the fracture occurred is it's pretty far-fetched. The third problem is that you have a changing history, so that's problematic as well. So then mother provides a new explanation, which is that the infant was in a baby swing and she pulled on the leg to slow down the swing. The conclusion at this point is that you have a changing and evolving history, and the type of injury itself is highly concerning for child physical abuse, and that you have a very young infant with a very large femur fracture. Regardless, you wouldn't expect this because infants don't, they don't walk. So they don't have any reason that they would develop this large femur fracture during routine activities. Otherwise, our emergency departments would be full of infants with femur fractures from having their diapers changed, for example. So fracture patterns, there are high specificity fractures, moderate specificity fractures, and then low specificity fractures. Keeping in mind that any of these fractures can be abusive and any of them can be accidental, basically. There's the bucket handle fracture, also known as the classic metaphyseal lesion or corner fracture or CML. Those are very high specificity for abuse. They're very rare in anything but abuse. I showed you the bucket handle in that first case that we looked at. We'll talk a little bit about the mechanism, but rib fractures as well are very highly specific for abuse. Scapula fractures, that's your shoulder blade, spinous process of the vertebral body, so part of the vertebral body, and then sternum, so you're right under your solar plexus. And then moderate specificity fractures are basically having multiple bilateral fractures, different ages fractures, fractures of different ages, vertebral body fractures, fractures of the fingers or toes, and complex skull fractures. And then there are the fractures that are much more commonly accidental. And these would tend to be in like your active mobile children, clavicle, long bone shaft, and linear skull fractures. So for example, if a parent were to say that they dropped their 6-month-old infant and they had a linear skull fracture, I actually would say that's reasonable. That's a history that fits the injury. So rib fracture is the most common fracture in child abuse. They're often diagnosed during the healing phase, and the posterior or back of the rib is the most common. And that's because there's levering across the vertebral bodies, and that's what causes the fracture to occur across the back. CPR is not known to be associated with rib fractures. So that's often an argument that's made in court, is that they got rib fractures from CPR. That does not happen. Metaphyseal fractures we talked about. The mechanism of these types of fractures is like a yanking, jerking, tugging of the extremity. They're most commonly in the legs. And they're very subtle. They're not impressive to people in juries, but they are very specific for abuse. So here are some more corner fractures or metaphyseal fractures or bucket handle fractures. Skull fractures, they can be abusive or occasionally accidental if you have a good history to explain them. Whereas a more complex skull fracture would be more concerning for inflicted injury and child physical abuse. Or a skull fracture that's of like the back of the skull or the front of the skull. The side of the skull is a much thinner portion of the skull and tends to get fractured more easily. So with a medical evaluation of skull fractures, again, we get a good history, make sure that we ask about any possibility of bone disease in the family, like underlying bone diseases that run in the family. Physical exam, laboratory analysis to look for things like vitamin D deficiency, although I could do an entire lecture about the significance of vitamin D deficiency or lack thereof. And then imaging, of course, as we talked about, skeletal surveys. I'm going to just kind of skip over this slide. I mean, basically, we talk about when fractures become symptomatic, and we get a very good timeline. But and we ask about what happened. As I told you, we ask very detailed questions about what happened, where it happened, when the child became symptomatic. And then why. So very commonly with a lot of the children, we see changing the diapers or changing the clothes, or the child crying or potty training is a precipitating event. But again, we're not investigators, so we're just asking basic questions about what was happening at the time that the fracture was noted. Red flags would be no history or history inconsistent with developmental abilities. Or mechanism inconsistent with the injury. I will say that in terms of fractures, about 75% of fractures, both abusive and non-abusive, are not associated with any bruising. And then the skeletal survey, again, x-rays done on all parts of the body, and we do them routinely in any child with a fracture who is under 2 years old. And then over 2 years who is nonverbal or has developmental delay or is is possibly in a coma and unable to communicate with us. And we repeat the skeletal survey because, as I told you, it gives us additional information. And that actually has been studied. And in about 46% of cases, there is additional information garnered by doing the follow-up skeletal survey 2 weeks later. Sometimes we were actually able to rule out things that we thought were fractures, and sometimes we're able to see things that we didn't know were fractures. In terms of the amount of radiation, it's about 100 chest x-rays or background radiation that you get from 8 months of being alive. So parents sometimes will use that as a reason why they don't want the skeletal survey, and that's what we say. So we do talk about dating fractures or being able to tell how old a fracture is. The callus usually forms in the first 5 to 14 days. And that's why we do the skeletal survey 14 days after the initial. And then by 3 months to a year, the fracture is completely gone. So we do have an ability to date or time fractures to some extent, depending on the type of fracture, especially long bone fractures. In addition to a skeletal survey, we do a head CT routinely on all infants with concern for abuse who are 6 months old or younger. We do AST, ALT, which are liver function tests for kids who are under 5 years old to rule out occult abdominal injury. We do bone labs, unfortunately, because we have to be able to argue in court that the child does not have a bone disease. And we consider doing other labs depending on the presentation of the child. Differential diagnosis, obstetrical injury, depending on the age of the child. If they're 7 days old and they have a new humerus fracture, then we would consider it to be possibly associated with birth. And then there are multiple diseases that do predispose to fracture, but they're usually pretty easy to rule out. I'm kind of rushing because I want to make sure that there's a little time for questions at the end. This is what rickets actually looks like. It's got this fraying of the ends of the bones. This is a 41-day-old who is not moving her left arm normally and is exclusively breastfed, and her bones appear gracile and willowy, and she was diagnosed with OI of unknown type. And you can see she has unusual appearing fractures. OI is osteogenesis imperfecta, which is a bone disease. There's 4 main types, and 2 of them can be confused with non-accidental trauma. And these are the 2 types that can be confused with non-accidental trauma. And these are just some features of osteogenesis imperfecta that we look for. So they have this blue appearance to the whites of their eyes. And then they have these unusual appearing teeth, some of them. There can be hearing loss in childhood. And they do tend to be easily fractured bones, but that tends to happen when they become mobile. Diagnosis of OI is usually pretty easy to make. Usually there's a family history, or you can tell on physical exam, and then there's genetic testing as well. Common misconceptions used to believe that every spiral fracture was indicative of abuse. There are toddler fractures, which occur when a toddler plants their leg and twists it, and there's a fracture of the end of the tibia, so right around the ankle. There is a misconception that fractures are always clinically obvious. So rib and metaphyseal fractures are usually pretty occult. And then there's a belief that short falls and stairway falls are common causes of fractures, which is not true. Short falls and stairway falls usually result in no injury at all. And I'm going to stop there and see if anyone has any questions, because there's no way I'm getting into abusive head trauma without a fight. So does anyone have any questions?
Yeah, I think this, if people do, this would be a good time to bring them up because, you know, we're getting not too far from the end of the hour, the bottom of the hour here. So I'm sure there are people who may have some things they want to talk about.
Are you doing through MCRC any education of physicians and other medical providers? And what would you suggest should be done?
Yeah, so we try to do grand rounds for other hospitals. I think the pandemic sort of put the kibosh on that a little bit, but we definitely offer ourselves. And unfortunately, sometimes it comes up as like something bad happened at a hospital or clinic, and they want us to come and do some teaching around those events. So yes, we do teaching is the short version of that.
There's a question in the chat box.
Oh, okay. And Greg, is it from you? Greg is?
No.
No? Okay. All right, let's see.
Oh, someone asked about, because it was an intact family. So here's the thing. There was a study done about analysis of missed cases of abusive head trauma. And they found that the most common cause of missed cases of abusive head trauma was a white intact family. And the person asked, how is that operationalized? Which I'm going to take to mean, how do you avoid that scenario? And so we're definitely very mindful of the fact that the child protection system has a problem with racial bias. And we try very hard to use the science and not use things like, how does the family make you feel? So often I'll have child protection workers say to me, well, you know, what was your read on the family? How did they act? How did they make you feel? How did they react? And I always say, you know, I don't really go by that. I don't really respond to those kinds of things because all I'm there to do is tell you what the science says. I try to really stick to that and tell you, you know, this is a child with a femur fracture and no history of trauma. And whether the family was crying or laughing doesn't really affect me.
So we have a question about whether the webinar is going to be available. We you know, with permission, I didn't actually specifically ask you, Doctor, about this, but we would like to take your slideshow and the recording of this and put it up on our website, because that is, as Stephanie indicated, that's a way a fair number of people actually access these webinars. So,
sure.
Yeah. Okay. And then Mark had a question. Mark Newpin had a question. Mark's a pediatrician as well. He's saying, are you aware of the Child Protection League? They advocate don't let a doctor talk privately with your child. So I think Mark has run into them on a number of occasions out in Anoka County. So.
Well, I'm not aware of them. Since we're only talking about physical abuse right now, generally my patient population don't talk. I do see some kids who talk. I see some kids, you know, who are verbal and who have been whipped with a, you know, cord or whatever. That's generally my population that talk. And I talk to them. But I don't have to, because generally I let the injuries speak for themselves. So honestly, I don't have to get a history from them on their own. I just take pictures of the injuries, and you know, I can have the parent there and I can ask them what happened. And if the child says that they fell in the bathtub and that's how they got these looped pattern injuries, I would say that those injuries are not consistent with the history that they're providing and are consistent with child abuse. And it doesn't really matter what the child says to me.
Okay, other questions? We do have a little time. There's a lot of people, so there's got to be a few questions. Well, I'll toss one out while we're waiting. As you know, we're doing a study of child fatalities, and we ran into a number of cases that we thought were child torture. So we consulted with a couple of experts who've done research on this topic. And there are three different standards that we used, and we asked the people who did the coding of the cases for this study to apply those standards. So depending on which standards, there's like agreement across the board on all of them about 5 or 6 kids, and there are certainly elements of torture in 15 or 16. That's out of 88. So we thought that was a pretty startling number. And the other piece of it is that generally speaking, those children tended to be older and not, infants or 2 or 3 year olds. So I don't know, is that, when those kids can talk, and I don't know if that's something you run into or if there's a difference. Again, I guess you're looking at the, at the injuries and not what the child or the parents say, but just thought you might have a thought about that.
About child torture?
Yeah.
Mm-hmm. Yeah, I mean, then we would probably interview the child, and but that's a whole separate arm of child physical abuse that I think, because you're also talking about emotional abuse, that I feel like it's not that it's not in my wheelhouse, it's just that I don't know that I could address it in the 1 minute that we have left.
Sure. Right. So
I brought this up because this came up in a Republican Party meeting. This is a political party group. And I was stunned when I brought this issue up. I was cursed and shouted at by the audience who agreed with this group that, and they even accused us pediatricians as being abusive predators. And I was stunned. So this abuse issue has become political. And I just wanted you to be aware of it if you weren't aware of this particular group, which speaks to various Republican groups.
Yeah, it's become political.
Okay, how about if you're up for it, one last question, and I think then we'll have to call time.
Hey, Rich, this is Stacy from Cashew. I have a quick question for Dr. Swenson. So we are focusing on interdisciplinary child welfare work this year, both in a publication and a conference. And I'm just curious from your experience at your Child Advocacy Center and in all your work as a pediatrician, where you see the most need is for strengthening interdisciplinary work.
You mean like multidisciplinary team?
Yeah. And like, are there other disciplines or people or staff, like just in your work that it's like, we need to collaborate better, we need to be talking, silos need to come down here, that kind of thing?
Oh, I just feel like we have a great multidisciplinary team. So I feel like I don't have anything bad to say about the MDT. I feel great about it, but that's just I'm just spoiled because Ramsey County works so well. We just do a really good job. But I feel like the lines of communication should always be open with your medical provider. I know that's not the answer that you wanted because I'm supposed to come up with the ways to improve, but I just feel like super lucky to have the team that I have.
No, that's great. Sounds like it's working well. So that's helpful. Thank you.